Hey everyone, just we'll give everyone a couple minutes to come from other meetings and then we'll get started. Thanks. Hey everyone, thanks for coming. I know a couple people are still in some other talks, so they've told me that they'll view the recording. So we'll go ahead and get started. Is everyone able to hear me well? Can you just give me a thumbs up? Okay, great. Okay, so again, yeah, this will be recorded and posted on all the social media sites, including the rusmclinical.com. So you feel free to view that later, and we'll be sending that out to everyone also. Okay, so um, we'll go ahead and get started. Okay, so just a quick introduction to our e-board. Our faculty advisor is Dr. Vivek. My name is Patrick. I'll just be giving you a quick presentation on what to expect in your rotation, kind of little tips that we have, and if you have any questions, feel free to ask at the end. And I'll also post at the end a link if you'd like to join our group. And we're a good resource for any information you need. please feel free to reach out. Okay, so just real quick, the goals of our interest group. We just want to promote interest in psychiatry as a whole. There's a lot of misconceptions about it. Foster a support network. If you have any questions, you can kind of turn to the chat. A lot of different people in there that know different things. So, we're always trying to be helpful, and you can always message me or any of the board members if you have any questions. We provide guidance. We have some resources. We have like an Excel sheet showing, where students have matched from our school in the past 5-ish years, and we're always updating it. So kind of give you an idea during match cycle of, kind of how to temper your applications and where to focus on. So that can be a good resource. And also, if you have questions about the different fields, there's like addiction psychiatry, forensic. There's a lot of cool subspecialties of psychiatry. So if that's something you're interested in, we definitely talk about that. Okay, so just to start off, we're just going to talk about what makes it unique. Uh, so it's one of the few specialties where you do holistic care. So you're focused on factors like trauma, housing and security, family dynamics, culture, neurobiology. So it can be very intellectually rich in that way if that's something you're interested in. Another huge draw is the diagnostic variety. So you'll see, everything from major depression, anxiety, schizophrenia, bipolar, PTSD, etc., personality disorders, which can be very challenging. So it really involves building rapport with the patient more than really any other specialty because they have to kind of be with you on the treatment. Otherwise, it can be really tough. Some days you'll need to, de-escalate an agitated patient. Others you'll be doing motivational interviewing with someone in early recovery. So it's a lot of good variety in that way. For the relationship building, it's really good for longitudinal care. When I did an outpatient addiction psychiatry elective. You just see patients that the attending has seen for 30 years, and they're just working through their issues, and they know them so well they don't have to read any of their notes. They just know them like almost like their family. So that's something you might be interested in. So you follow them over, many years. You see their major shifts in functioning, their relationships, their quality of life, and it's not unusual for the patient to be like, you're the first person to ever really listen to me. They view you as, authority figure in their life if they've never had one. So it's a lot of cool different dynamics that you can develop with the patient. We also see a huge impact on daily functioning uh, with even small clinical wins. So, if you help them manage their anxiety, it can go through their whole life and improve everything in their life. Even just titrating meds here and there, can have huge effects on their life in tangible ways. So, in psychiatry, you're not always curing disease, unfortunately, but you can, give them some autonomy on in their life, and it can be very rewarding in that way. And then finally, the field of psychiatry is really going through constant evolution. It's like one of the last emerging unexplored areas of medicine. So, there's new things like ketamine, psychedelic assisted psychotherapy, neuroimaging, genetics, mental health platform, new digital mental health platforms. That's all the rave now. So there's a lot of progress being had. So it's kind of cool to be in the middle of that. So and there's a lot of new good research happening. So that's also something to look forward to. Okay, so for your rotation, for your clinical environments, there's a lot of different settings. So depending on where you're doing your core, you'll see different things. I did mine at Trinity Health Oakland in Pontiac, so it's mostly inpatient, and we did do some partial hospitalization, which I'll explain in a second. Um, and yeah, so there's large range of practice settings. So like for outpatient, it's pretty self-explanatory. Like I said, you're meeting with patients, developing relationships. You may see them for weeks, months, years, etc. So it's great for someone who likes the continuity. And then inpatient will be for sure the largest component of your rotation. So that's the more acute, high intensity. You're working on locked units with the patients who are often in crisis. They're having manic episodes, suicidal ideation, psychosis, severe depression, etc. Yeah, so your primary goal there usually is stabilization and safety. So you're part of a larger care team, uh, including nursing, social work, occupational therapy, care management, etc. So rounds are often like collaborative, and discharge planning can take a very long time depending on their support system and what kind of income they have, etc. So it's fast paced. It gives you a front row seat. You can see the more severe end of the psychiatric illnesses. Also, a big component of your rotation will likely be consult liaison psychiatry. So it's just like the bridge between the rest of medicine and psychiatry. So you'll be going to like, your general hospital floors like surgical wards, ICU, OB floors, and you're consulted for a wide variety of concerns for the medically ill patients. Like it could be evaluating someone for delirium, doing capacity assessment, post-stroke depression, complex like somatic symptom presentations. So it's ideal for people who like to, keep their medicine, quote unquote, fresh in their mind while still, having psych intertwined with it. And then community mental health. So you're working with patients who have severe mental illness who are often uninsured, underhoused, they have systemic inequalities. So it's really meaningful work if that's something you're interested in. As everyone knows, there's just a shortage of mental health providers, so that's something that's desperately needed in the community. And then finally, there's the partial hospitalization programs that I was mentioning, the PHPs. So these are structured intensive outpatient programs for patients who need more than a standard clinic, but don't require the 24-hour inpatient care. So it's kind of like a middle ground. It's usually 5 days a week for several hours a day. They may go to like group therapy, med management, um, individual sessions, CBT, DBT. So it's kind of like a step down care for inpatient stay. So they may have been inpatient for many weeks, but they're not ready to, fully go on their own. So it's kind of like an in between stage. So you may encounter that in your rotation also. So it's just a cool mix of different things you might see during your rotation. Okay, so just some do's and don'ts. Okay, so for the do's, approach you'll see a lot of delusions in your rotation. That's one of the number one symptoms you'll see. So approach it with curiosity, but do not be confrontational. So when a patient shares a delusional belief, your job is not to challenge or correct them. You may feel tempted to do so, but it's just not in the best interest for you or the patient. So try to use neutral language like, help me understand what you're saying. Can you tell me a little bit more about that? Don't try to be so confrontational. Don't try to explain, oh no, that's not the way the truth, the reality is, because then that can be, seen as combative, and then the patient doesn't want to open up to you in a way. So you'll kind of destroy that therapeutic alliance if you do that. So maintain a calm, compassionate tone, even under stress. Like you're going to see some patients kind of challenge you. Unfortunately, just that's just the way that it is in the inpatient side. So your tone, your body language, it all matters. So even if the patient's agitated, if you just try to de-escalate, try to be grounded, the patient can feed off that. Whereas if you get stressed out, patient may, escalate that. Nobody wants that. So, connected to that, set firm but respectful boundaries when needed. So, patient may test limits, sometimes intentionally, sometimes not. So, phrases like, I want to continue talking, but I need you to speak to me respectfully are good examples of, how to maintain limits but not be disrespectful to the patient, you know, d regardless of what they're going through. Yeah, so seek collateral info to understand, not to catch in lies. So, I mean, as you can expect, you will see patients lie to you. They'll tell you something one day, you'll hear the opposite the next day, or they'll tell you something and a resident or attending will be like, that's not true because they, called their mother or their partner and they found out the opposite. So we're not trying to bust the patient, we're just trying to help them the best we can. So they may misrepresent themselves due to fear, due to stigma, due to past trauma. So, don't take it personally. For the don'ts, don't anchor too early. This is very important. So you see a patient that comes in with the diagnosis of schizophrenia, you don't just automatically think, okay, schizophrenia, everything this patient tells me from now on, I'm going to think of it in the lens of schizophrenia. That's not a great way to do it because they may not be coming in with that issue. So the current presentation may not be psychosis, even though they have a history of schizophrenia. So you can consider other things like medical causes, personality factors, substance use. Like let's say a patient has schizophrenia, then they use a substance. Are you going to blame their current mental state on the substance or the schizophrenia? These are things you want to delineate and not just assume everything is the schizophrenia. So you just want to kind of keep it broad as early as you early on, and then you can kind of narrow down as you learn more. So yeah, don't be easily offended by challenging behavior. So like I was saying earlier, you don't take it personally. These patients are going through a lot. It can manifest in, many different ways with emotional outbursts. They could be fighting with the person in their room and take it out on you. Just, try to be objective as possible. Don't try not to be, you might get your emotions hurt. That's okay, but just try not to take it personal and know that they're going through something. Okay, and in that vein, don't let inappropriate behavior go undressed. So, you your boundaries are very important. You don't want to allow unsafe behavior to occur because that doesn't help you or the patient. So a lot of things you'll learn is how to redirect. If a patient is, escalating things, you may see how your attending deals with it, and you can kind of learn on how to do that. Or say, this is not going well. I'd love to speak to you at a different time and just leave. That's sometimes the best option. So you just learn how to set limits without being, too confrontational. Okay, and then this is huge. Don't ignore staff safety protocols. So there's nurses, techs, security staff. Uh, they're your best allies. If they advise caution, take it seriously. Always know where the exits are. If something feels unsafe, trust your instincts, step away. There's protocols that have been improved through many years. So if they tell you something and you're thinking, oh, this doesn't it's not that important. They may have implemented that rule because something happened in the past. So even if it doesn't make sense to you, try to follow the protocol. So like if they tell you only interview patients in certain areas, don't just say, oh no, the patient was nice to me yesterday. Let me just go to their room and talk. Like you want to follow the rules because there's reasons for it if something happens, etc. So you just want to respect their rules and don't do anything outside of that. Okay, so what are the expectations for you uh, as a student? So taking psychiatric histories and a focused ROS, we'll be going to that in a second. So you'll be expected to take the review of systems. You can, including things like mood, anxiety, psychosis, sleep, appetite, etc. Often includes suicidality, homicidality, and learning how to ask these questions in a way that's natural, builds trust with patients, is very important. So you'll learn that over time. Performing the mental status exam, the MSE, and the MOCA, the Montreal Cognitive Assessment, very important. So we'll go over those in a second. So the MSE is your quote unquote physical exam in psychiatry. So you need to observe and describe how is the patient dressed? How do they speak? Is their mood congruent with their affect? Are their thoughts logical? So this is something that takes practice. And then you'll most likely use tools like the MOCA, especially in older patients with memory concerns. And I'll show you a couple tips for that in a second. So building rapport, as we said before, being non-judgmental, that's very important because patients may be paranoid, guarded, experiencing psychosis. So how you present yourself can break that interaction. So speaking calmly, never reacting with like huge surprise or judgment to what the patient tells you is very important. Engaging in team activities. So you'll see on the floors that patients are encouraged to go to therapy groups, family meetings, collateral calls. You'll be doing collateral calls with nursing staff to kind of find out more about the patient. So it's a lot of interdisciplinary things going on. So the more you can get involved, the more it looks good for you, and the more you'll learn in this rotation. Not be ignorant of all the things that go on in the background with case managers, therapists, etc. So if someone's going to a group therapy session, you can ask if you can observe and just see how that patient does there. Sometimes they'll be open to you in private, but extremely closed in the therapy session. That's something you can bring up to your attending and something, they may want to explore and, encourage the patient to be more open. There's family meetings where, the family will come in, you'll kind of discuss with the patient and the family, see what's going on, see what they can do at discharge to make everything go better to kind of prevent this from happening again. Something I encourage is so take ownership of 1 to 2 patients, unless you're assigned more, but generally, they start you off slow. So know their history, their meds, their labs, their plan. You should kind of really know everything about that patient so that when you're rounding on that patient and there's a question, you should be able to answer it. So like, knowing their DSM diagnoses, their med list, any side effects they've been complaining about, any recent lab values from the med side, their social support. So the more ownership you take, it makes your presentations look sharper and makes the team trust you more. And then lastly, as everyone knows, read up on your diagnosis. And meds that you encounter. So just make it a habit, like to read on the criteria for an illness. As everyone knows from studying step one, the time periods are very important. So kind of review those for your patients, the side effects, the indications for certain things like ECT as an option. Just things like that can be very important. Okay, so the review of systems in psychiatry is a little different. So than the usual ones that we've learned about. So we're trying to rule in and rule out disorders like, MDD, bipolar, psychotic disorders. So as you gain experience, you'll learn how to phrase these questions to get more honest answers. So, building trust here is huge because in psychiatry, there's also a stigma that patients don't want to answer every question you ask them, unlike on the floors where they're less likely to withhold answers, for physical symptoms. So, for example, for with psychosis and hallucinations, if they have auditory hallucinations, you can try to delineate more about asking about command hallucinations. Are the voices telling them to harm themselves or others? Right? You don't want to be judgmental, but you do want to kind of learn more about it because there are different diagnoses with different, that are more likely with different types of hallucinations. So this is something to ask about and present also. So if they've had like they may have limited insight. So if they've had hallucinations, it does not always give an accurate. They don't always give an accurate response about, oh, hey, yeah, I have hallucinations. Like they may not answer like that because they don't view it the same way they may view it as a real person. So why would they, tell you it's hallucination? So the more you learn how to speak with them, you can kind of find the differences about, oh, are other people, receiving the same instructions that you are? Once you get more familiar with the patient, you'll learn different questions to ask. So like, for example, I notice you've been talking a lot while walking down the hall. Is there anyone you've been talking to? Are they saying anything back to you? What types of things are they saying, in a non-judgmental way? Okay, so our approach. So you want to start with open-ended questions, then narrow in. So beginning by giving the patient space to speak freely, you could ask, can you tell me what's been going on with you emotionally? So it's like a very general question that you start off with, and then they may tell you things that you didn't read about in the note, you didn't realize, and then you can kind of focus in and targeting specific symptoms like mood, anxiety, sleep, appetite, substance abuse, stuff like that. No, so yeah, so normalize questions to reduce stigma. So critical technique is destigmatizing. So phrases like a lot of people under stress experience anxiousness or even hopelessness. Have you had thoughts like that? So you're not just saying, "Hey, I know you're experiencing this." You're not accusing them of anything. You're just saying a lot of people experience anxiousness. Have you had thoughts like that? So it's kind of a more soft way to speak with them. So it allows the patient to feel less judged and being less pathologized. So you want to be thorough, but you also want to prioritize because if you're going to ask every single question in the book, you're going to be there for hours. But you want to kind of get a general understanding, and then once you kind of have an idea, you can ask, more specific questions. So like if someone is presenting with panic symptoms, you could focus more on the anxiety, the mood, the substance use, not just the psychosis or the mania aspects. And then just to reiterate, um, always assess safety. So no matter what the patient comes in for, a lot of times you're going to be encouraged to ask about suicide and homicide because safety is the number one priority when these patients present. So it is okay with, given the right context to ask, have you had thoughts of hurting yourself or someone else? This is very common that you'll hear because it's very important to get the answer. Um, yeah, so let's say a patient presents with like a low mood. You can screen for other depressive symptoms like sleep issues, appetite changes, concentration, guilt. So these are all components of MDD diagnosis. So these are, kind of telling you where to focus on your ROS. And then based on your findings of how they answer these questions, you'll get different answers. Like, is it unipolar depression, bipolar, anxiety with depressive features, or even something on the medical side? So, it's important to keep that in mind. Okay, so for the mental status exam, um, so it's an assessment of a patient's level of their cognitive ability, their appearance, their emotional mood, speech, thought patterns at the time of the eval. It's just one part of a full neuro exam. It includes your observations as well as the patient's attitudes and cooperativeness. It's part of the objective portion of your SOAP note. So, for example, like if you're asking about the speech portion, you observe the rate. Is it slow versus pressured? The volume, whispered or loud? Coherence. Are they fluid? Are they fluent? Does the speech flow logically or is it fragmented? Is it a fluid speech? So the ROS identifies symptoms. The mental status exam evaluates their current mental state. Both are very important for treatment planning. And again, just as a reminder to always assess safety. Okay, so this is an example of the MoCA, the Montreal Cognitive Assessment. You will be giving this on the floors in the ER, in the unit. So if you've never seen it, this is what it looks like. I'll just go into a couple quick examples of something that I see students kind of mess up, including myself. So it takes about 10 minutes to administer. It's like a rapid screening instrument. It's not diagnostic on its own, but it's a powerful screening and monitoring tool. So you'll see it a lot in inpatient units, outpatient geriatrics. You may also heard of the mini mental state exam, the MMSE. It's like a set of 11 questions. It's used to check for cognitive impairment. So there's a lot of similarities between that and the MoCA. I'll go into the MoCA, but you'll be able to understand that one as well. So there's many versions. This is 8.3. It's because if you're giving this test to your patient, different times, you don't want them to have the answers memorized in a way. So your attending may tell you go administer the MoCA to a patient on the floors or in the unit, report back with a score and the filled out paper. So you can easily find the instructions and grading criteria just by Googling MoCA test online. And I'll just give you some quick examples of that. If you can't find it, feel free to message me. I can send it over to you. It seems obvious on how to administer it, but there are examples where I've seen, several students kind of mess it up, including myself in the beginning. So I'll just show you just some quick examples. Okay, so for like the clock portion, um, so the tests will have very specific rules. This is the criteria for grading it, and then I highlighted if the subject places some numbers inside the clock contour and some outside the clock contour, he or she does not receive a full point for numbers. So had you not read this, you may think, oh, this, looks fine, just the numbers are a little off, but that should still be fine. But with the criteria of the test, they would get no points for the number portion with this example in the top left. So it just kind of shows you sometimes it can be a little nitpicky. Even if one number is out of the circle, they lose all the points in the whole point of the number section. So just like a little example of that. Okay, and then I just kind of zoomed in just so you can get a look. So they'll have to copy this picture here, draw lines from the first number to the first letter, uh, state the animal names, etc. So just kind of let you zoom in on that. And this is the second half of it. So there's a lot of little different tests. Takes about 10 minutes, like I said. And you'll familiarize yourself with it as you move forward. Okay, and just one more example of places where people can easily make a mistake if you don't read through it. So, like the instructions for the serial sevens is now I will ask you to count by subtracting 7 from 60 and then keep subtracting 7 from your answer until I tell you to stop. So let's say the patient starts and says, okay, 52, 45, 38. They already screwed up the 7 from the beginning because it should be 53, not 52. So even though they messed up the beginning, they still get full points because after they made their initial mistake, they did successfully subtract by sevens after. So you're allowed to make a mistake if you read this criteria, even though you started off, you know, incorrectly and all your subsequent numbers are wrong. The fact that you did subtract by 7 each time does give you full points. So that's like something surprising you wouldn't expect from the way they want you to do it. So I would just, before your rotation, find the PDF, just familiarize yourself with the grading criteria and the little rules that can be here and there. It'll help you do it a little more smoothly, and you won't have to be corrected by it because all the residents and attendings know this like the back of their hand because they've given it 1,000 times. So it's just something to give you, a uh, little heads up on. Okay, and then for the scoring system, so if 26 and above, that's normal performance, mild impairment 18 to 25, moderate 10 to 17, and then less than 10 is severe. Another thing that students often forget is you add a point if they have uh, less than or equal to 12 years of education. So 12 total years, not just they went through, kindergarten to 12th grade, just if they have 12 years total of less than 12 years total of education, they gain a point to kind of even the odds there. So again, it's not diagnostic. You got to interpret it in a clinical context. Like there's common pitfalls to it. There's cultural biases, educational biases, visual and motor impairments could affect performance, which wouldn't be indicated on just the score alone. Like you can imagine if a patient has severe Parkinson's, it'd be hard to draw a clock, even if cognitively they understand what to do. It's just going to be physically hard. Yeah, so you may be told to go give the MOCA, and the more you understand about it, and just kind of just read through the document so you can kind of be reoriented with it from the get-go. And you might be asked to go give it to the same patient over and over again during their stay, like every other day, and you can see how they improve or they decline. So that's something you might be asked to do. And then I'll just leave you. Our interest group has a presentation on catatonia on Monday. It's at 7 p.m. with Dr. Singla. So please join us for that. If you are not part of the interest group WhatsApp, I'll link it right now. And that will be it for us. But we're all here for any questions you have. So please feel free to ask any questions, and we'll do our best to answer that for you. And I'll go ahead and link that stuff in the chat. So please feel free. And again, like I said, this will all be posted online, uh, the video. So if you have any questions, so the first link there is a form to join our group, and the second link is the WhatsApp group. So if you'd like to join, just go ahead and click that. And if you don't have any questions, we appreciate you stopping by, and hope you come to our presentation on Monday on catatonia. It's be important if you want to be a part of the interest group. It'll be a nice presentation there. I do see someone is typing, so we'll just wait for that question. What are the two common mistakes you've seen students do and should avoid? Sorry for no, that's okay. Um, so in general, I've seen students kind of like the second they're challenged by a patient, they just kind of shut down and they kind of end the interview. I don't mean challenge like in a physical way or anything like that. I just mean like when the patient is not just overtly answering the question, I'll see them just kind of like, oh, okay, thank you, and just leave instead of kind of trying to explore that. So I think that's like a common mistake I see. And then the biggest one I would say, which is why I included it, is the anchoring bias that a lot of students have. So in my example with the schizophrenia, like, oh, no, that patient has schizophrenia. So anything they say, I'm going to think about schizophrenia, regardless of what it is. If they're complaining about anything, I'm going to say it's schizophrenia. So I see that anchoring bias it's something that you should try to get rid of, whether you're in medicine, non-psychiatry or psychiatry. It's just something that, oh, you see a diagnosis, you associate it from now on with everything they do. So I think that's a common mistake. And then as far as doing the tests, like I was explaining with the MOCA, there's just a lot of easy things to mess up as far as grading. So if an experienced person was to grade the same exact MOCA as, let's say, me as a new student, they would get a far different score just because I didn't understand the criteria. So that's just something I encourage you to read from that PDF. Um, if any other of the board members have any answers uh, that they can think of, please feel free to chime in. No problem.
I'd also add one mistake, and I've made this myself, is when you're asking questions, you want to phrase it in a way where, like Patrick said, you don't want to challenge them or introduce stigma. With questions like substance use, a lot of patients don't want to be honest with it. And even if you know that they have a history, you want to phrase it in a way where they feel okay with being honest with it. And then with other like mood symptoms or psychosis, if you're asking about hallucinations, a lot of these patients don't really have insight. So even if you're outright asking about hallucinations, they're not going to be aware enough to like notice that they're hallucinations. So you just have to be kind of creative in the way that you're asking questions, and that's kind of something you learn with time, because when you're first starting out, you don't really know how to ask these questions.
I agree completely. Yeah. I think in the beginning, it's very difficult to understand where to interject, how to ask, how to do it without being too confrontational. And then as you watch a bunch of attendings and residents do over time, you start to think, oh, okay, that's a cool way to ask that without being weird about it. So I think that's a good way to do it. If you guys have any other questions, please feel free. And, we appreciate your time. Okay, so since we are USIMGs, what are some things we can do during electives and even as we work on our apps to put ourselves in a good position? Yeah. So, there's rumors going around that psych is getting a little more competitive. Maybe that's true. It's not getting, insanely competitive, but there are certain things you can do. As far as doing like a sub I to get a really good letter of rec, that's something that, when they pull the program directors of psychiatry residencies, actually one of the top things that they list as importance is not even a step two score. It's shows genuine interest in psychiatry. So they, more than other specialties, don't like it when students are applying secondarily to psychiatry because they can kind of sniff that out. They've been doing this for thousands of apps. So the more that you can show that, oh, psychiatry is my primary interest, like getting involved with the interest group, doing case reports on psych, volunteering in psych specific stuff. The more you can show that you are more all in on psych, unfortunately, that's just the way the game is played, will increase your chances. So I think like let's say you are on the floors and a patient presents with a weird symptoms, and it's a cool diagnosis that's not usually seen every day. I think if you write a case report on it, maybe create a poster on it, present it somewhere. When they read your application, they'll be able to say, "Oh, no, this person is into psych. They're not just applying to, radiology and backing up with psych," because they kind of want people who are all in and not just, secondarily doing it. So I think that's something huge. I don't know if anyone else has any other suggestions.
Yeah, can y'all hear me?
Yeah, we can hear you.
Okay. Yeah, I agree. The interest is a big thing. But I think also I don't know where everybody is in their like journey right now, third year, fourth year. But I think another thing that's important is applying to programs that like their mission statement kind of resonates with you. Um, and kind of doing activities and volunteer work and just work with that population of work like in that specific dynamic that you want to work in. But interest also, like you said, is a big one. Make sure you're getting rec letters. I know everybody says like two from like the specialty what you want to go into. Honestly, I would go as far for psych to say even three or four. Um, just because it shows, hey, they actually put time and effort into doing well on these psych rotations, and the psychiatrist saw enough in them to write this great letter recommendation from them. Um, yeah, I agree. I think the biggest thing was interest and letter recommendations, and volunteer work. You can get into like some volunteer work, some community service. Um, that was also a big thing.
Yeah, I agree. So, with the volunteer work, there's just another thing to add to show that you are all in on the psych, uh, on the psych aspect, because especially if it's psych specific volunteering. Let's say you work at a community health clinic or, et cetera, for psych related stuff. I think that's important. Unfortunately, research is kind of hard to come by in psych. If you're fortunate, you can find some. That's another thing. But it's a lot easier to find that like in IM and whatnot. So any of these things you can do, and that's why trying to stay on top of the rotation so that you can get a strong letter is very important instead of more of a generic one, because they'll read these letters more carefully to kind of try to figure out, oh, is this student really trying to go for psych all the way? So getting a strong letter is more important in psych than I would say most other specialties. So if you guys have any other questions, please, let us know. And if not, thanks for coming. Feel free. Yeah, no problem at all. Um, yeah, if you guys don't have any other questions, thanks for coming. We really appreciate it and hope you'll join us on Monday for this lecture. And we'll stick around for a couple minutes if you have any other questions. No problem at all. Thanks, guys, for coming. We'll see you on Monday.